So, moving on to our third speaker this morning. Looking at her biography, she could have been one of those people that I was describing in the first of our ADASS asks, namely cross-government, cross-sector engagement, because she's worked across government, across organisations, with roles at DHSC, Public Health England, CQC, the Cabinet Office. There's only one that you haven't worked for yet that is bigger than all of those, ADASS. So, challenge for you. Can I introduce Sally Warren, directly at the King's Fund, who I'm certainly looking forward to hearing and seeing how she can add to this fantastic wealth of knowledge and experience and views we have this morning. Sally, over to you, please.
Great. Thank you very much, Stephen. Good morning, everybody. I don't have slides today, so you've got a full-size version of me. I should have thought about this and just put some pictures to make me smaller. So I'm really delighted to join you all this morning. As Stephen said, I'm the Director of Policy at the King's Fund, and before that had a long career in national policy and regulation, predominantly around social care, but more generally in health and care. I think I do hold the record for the civil servant that's drafted the most number of green and white papers on social care reform where nothing's then happened. That's not a great record to hold. So what I wanted to talk about today was what reforms have accelerated through COVID, and then looking forward to think through how we can use the COVID experience to think about the kind of health and care system we want in the future. So thinking about what's accelerated during the COVID period, at one level, I think we need to say we don't really know. We don't have a lot of data. The data we do have tends to be about hospitals, which is a lot about process and input, but we really don't have much data about outcomes, about the impact of what's happening through COVID on people's lives. And that's why it's so important to hear the stories that Anna so articulately talked about at the start of the session, to really understand what people's real day-to-day experience have been through COVID. I think some of the things that I've picked up through stories I and my King's Fund colleagues have heard is that there's definitely a very varied picture. So for every positive you can draw out, you can equally draw out a story which is the exact opposite of this. So, for example, with direct payments, I know some users have felt that actually they've been given significantly more freedoms and more sort of permission to spend in this period than they might normally, less need to account and audit for every penny, and they've seen that as really positive. But in other areas, they've seen services be restricted to kind of hold back for the most critically in need. So actually their quality of life has been considerably less during the COVID period than before. And when you add on to that the numbers of people shielding and being very isolated because of that, that's difficult. From a staff point of view, again, we've seen some examples where social workers are saying they've been trusted much more to make decisions themselves rather than needing to refer everything to funding panels. So they've felt more free to be able to make decisions which are about supporting people immediately. So again, that's a positive, but it's not happening everywhere. We've then seen some other accelerations on particularly around the health and care interface. So digital GP appointments, digital outpatient appointments, kind of digital virtual kind of ward rounds in care homes. But again, for all of the good we've seen for some GP practices and their relationships, particularly with care homes, we've seen examples where care homes felt quite abandoned by their GP colleagues as well. And then on hospital discharge, obviously Matthew's talked a lot about that. There were a number of benefits to come from hospital discharge much quicker, but we should also acknowledge there were some real challenges that came from that policy. And as we look to learn and implement new policies to prepare us for the next wave and for winter, we need to be honest with ourselves about learning the positive, but also thinking what is it that we need to be cautious against. So I think for me, in terms of what has COVID done, I think there's a particular challenge for us in the adult social care sector that says we do need to be able to have more data that is more timely and more meaningful to really help us understand what transformation we're seeing, and for us to be able to understand what's driving the variation. Any public service has variation, of course it does, but it does feel that particularly people's experience in COVID has been highly varied. So those issues I'm sure we'll come back to throughout the next couple of days. So it's clear to, I think, all of us that COVID will be a big catalyst for change. The question for me becomes, is that a catalyst for more centralisation, more institutionalised based care? So does it become quite hospital focused? Or is it actually a catalyst for a much more devolved approach to health and care, which is predominantly around health and well-being rather than sickness and crisis? I very much hope it's the latter. The King's Fund has just in the last week set out our 5 priorities for what we've called the road to renewal. So kind of what we think needs to happen after COVID. I'm going to talk just about a couple of those in detail today, but I will then just briefly go through all 5 at the end. So you've seen, because I think the 2 I'm going to focus on are particularly important about how we really think about person-centred and person-led joined up care, and then particularly how we think about inequalities. So if we want that personalised care, if we want person-centred care, what is it that we need to do to make that happen? So I think none of these are simple answers. So I'm going to be saying an awful lot of things where you may well say, that sounds great, but how do we make that happen? And I think the answer is we collectively need to work through the how we make it happen. I think we need a completely different attitude, which is about a move from a sickness service to a service that's much more focused on population health and well-being. And that means a system and a sector that has different relationships. So different relationships between communities and the public agencies that work alongside them, different relationships between different public agencies, and then different relationships between national, regional and local organisations and systems that support and reinforce that locally led action and change. So those different relationships across all those different spectrums should be about communities having much more power to drive improvements in health and care that matter most to them. Should be about better partnership working and alignment between the NHS, adult social care, wider public services and the voluntary and community sector. And then finally, it's about national policies, regulation and funding flows and systems that are designed in a way to reinforce local leadership and local driving of improvements. Whilst all of that sounds quite ambitious and grand, we have got good examples of local areas who are on the journey to wanting to make that shift in those relationships. And what we've seen through those local areas is it takes real commitment and determination to stay the course. It needs recognition from leaders and communities and organisations as a whole that this is a massive cultural change. It's not a transaction, it's not a process, it's not a structure. It's a completely different way of thinking about our role as a public agency in a wider system. I think another strong feature in a number of these areas, and some of the areas that have been doing it, are things like Wigan, Healthier Fleetwood. We also saw some of this around the response in the aftermath of Grenfell. A strong feature is often the trust that gets placed in frontline staff to both know their communities really well and then to know how to do the right thing. That trust placed on staff can improve outcomes for individuals and communities. It can also improve job satisfaction of staff. But it's really important to say it's not guaranteed that that works, providing kind of just saying we trust you. Frontline, we trust you. We've seen some examples where it has worked really well, but we've seen other examples where staff have felt quite exposed and they felt under supported. So a real importance here is how leaders stay the course and help people feel that there is genuine commitment to that devolution of trust and power to the front line. So this requires, obviously, that kind of shift in a change of relationship between public services and communities requires a really big shift. So for me, a key focus of the renewal of services after COVID is a real focus on health and care services, better understanding and working with community priorities, needs and strengths. A really important role for the public sector to safeguard the role of the voluntary and community sector as a really long-term partner. And I think one of the long-term consequences the sector is going to feel is the impact of the COVID period on the financial position of voluntary and community sectors, and that could be something we feel for a very long time. And then we also need national organisations to recognise their behaviours, decisions and policies need to support and sit behind a locally led approach and not kind of counter that. I'll also add one thing that we need to avoid doing, which is don't focus on hospitals at the expense of the rest of the system, because it's the rest of the system where you can really improve people's outcomes and really change that relationship between services and the communities. So yes, we need to improve things in hospitals, but it shouldn't be at the expense of other parts of the system. The kind of next area that I want to reflect on is the inequalities which COVID has, I think, brought more into the public consciousness. I think many of us will be very familiar with some of the stats about COVID, about inequalities before COVID, and indeed the stats of the COVID period itself. So just to remind you of some of it, so on inequalities in life expectancy, men in the least deprived areas can expect to live 9.4 years longer than those in the most deprived areas. Those living in the most deprived areas can expect to live about a third of their shorter lives in poor health as well. So we have a really wide and stark inequalities across the country, and that has been exacerbated by disproportionate toll on groups that already face the worst outcomes through COVID. So the King's Fund thinks there's 3 things that need to happen to start to tackle inequalities properly, and we start from this on the basis that if you look, for example, in the 2000s, we did manage to reduce inequalities in the 2000s. So we do know what we can do about this. It requires effort, it requires focus, but we can make progress on this area. So the 3 things that we think that need to be done to really tackle health inequalities. The first is to have a government inequality strategy. That needs to have ambitious and binding targets. It needs to have faster progress across a whole range of wider determinants, which is very much about recognising health inequalities isn't just about the health and care system. And it should be a government inequality strategy that isn't afraid to use all the levers available to government, which should include tax and regulation as well. The one important thing to say, by saying we want a government inequality strategy, that isn't saying that you have to have a centralised approach to inequalities. That is, for me, about saying you've got to have serious commitment across government that that's an outcome you want to see progress against. You need to make sure that you in central government do the things that only central government can do, hence tax, some aspects of regulation, but you should also be clear about the levers and the kind of where the power and accountability sits elsewhere in the system to be able to drive change. So the first is that government inequalities strategy. Then if I maybe start to move us from that bigger picture about wider determinants into a bit more of the familiar territory of the health and care system, we think that inequalities needs to be a much stronger focus of the new integrated care systems than they are, and in particular that we should make sure inequalities is reflected in how ICSs are constituted, measured and held to account. So this not being ICSs predominantly about the delivery of systems and then a sort of nice to have inequalities aspect, but it being absolutely core to why they exist and why they're bringing those partners together. And then finally, and this is kind of, we've gone from a big funnel to a slightly smaller one, then to a specific focus on the NHS. I absolutely do recognise that we require more than the NHS to act on inequalities, but we do think the NHS itself could be more ambitious in its approach to inequalities. And in particular, that means investing more in prevention. It means reducing inequalities in access to services for some population groups. And it also means how can it leverage its assets, spending power and role of an employer more in the local and regional economy. That's sometimes called the NHS's role as an anchor institute, sometimes its economic agent role. But that sense of the NHS through its actions as in some areas the largest employer is really important. So that was my kind of summary of 2 of our 5 areas which we think we should look at. So thinking about a step change in inequalities in public health and reshaping the relationships between communities and the public. We also think alongside those 2 areas, the other 3 to make up our what's the 5 that we think government and health and care leaders should really be focusing on is lasting reform of social care, putting the workforce centre stage and embedding and accelerating digital change, which is probably the area we've seen the most startling progress during the COVID period. I'm very happy to answer any questions about those as we get into Q&A. We also have a number of pitfalls we've set out to avoid, and just aware of time, that might be something we can pick up in Q&A as well. But whilst it's always good to say what you should do, part of what we need to get better at in health and care is to learn from what's happened before and avoid making the mistakes we've made before as a health and care system. But at that point, I'll finish and hand back to Stephen. Thank you very much for your time.